Right. Hi, everybody. We're an hour and a half into the session. Karim and I, who are the last speakers, are very happy that you're still with us and you're still awake. Karim has something very special planned for you after this, so I'll be a short intermezzo. um, so what I'll do, I was asked to talk to you a little bit about the cohort research that we've been doing in LongITools, and the research and sort of policy implications that have come from that. Basically, what I was told to do is talk a bit about LongITools, talk a bit about Generation R, talk a bit about all the LongITools results. And by the way, you have about 10 minutes. So that's what you're going to get. So it's going to be a bit of a few highlights and a few extracts of what we've done, and I'm of course very happy to discuss in more detail. I'll try to take you through this relatively quickly. So within LongITools, you've seen the left figure already. We take a life course approach. You can see it sort of starting on the left with the pregnant lady, and then in the circle, the entire life course is depicted. And the reason why that is important is shown in the graph on the right, where we see age or time on the x-axis and chronic disease risk on the y-axis. And we know that the chronic disease risk increases with age. And what we're trying to do is to prevent or at least delay the occurrence of these chronic diseases. And so it's important that we determine when these diseases occur and when would be optimal times to intervene and what we should do at those times. So no need to look at the details of this graph, but this is a figure that we used in the original application. And basically it shows you a list of the cohorts that are involved. So message here, quite a few cohort studies involved in LongITools. And you see that they range from sort of early life cohorts starting around pregnancy or at birth, going through childhood, adolescence, adulthood, and into old age. And you see that some start in early life. This is the area that I work in, and then some are more focused on midlife or later life. For the sake of time, and because it's my comfort zone, I'm going to focus a little bit on the early phase of life, but similar things are ongoing in the cohorts that focus on the later ages. The other thing to notice from this graph is there are lots of little circles. From this graph, I mean, there are lots of little circles. So the circles in the middle depict the different follow-up times. So many things measured at multiple times. We're following in these studies large groups of people over time, have them come in for measurements, questionnaires, biological samples, etc., and basically follow how they're doing. And on the right, you see that there's also a lot of outcomes measured. So we see what happens to their health and their well-being. And that is basically the setup of the cohort studies in LongITools. Now, as an example, I work with the Generation R study, which is located in Rotterdam in the Netherlands. It's for Dutch circumstances a big city, but it is really not compared to many other countries. But it's the second largest city of the country. And Generation R is a population-based prospective cohort study that started in early fetal life. So around the 12th week of pregnancy, we basically asked all pregnant women with due dates between 2002 and 2006 whether they were interested in participating in a long-term follow-up study. 10,000 of them said yes. It's about 62% of the women we asked. And we've been following them for over 20 years now. Clearly, some people stopped their participation. We have about 75% of the original cohort still in active follow-up, which means that they either come to us for measurements or we send them questionnaires, etc. We at least know where they are and roughly how they're doing. A specific aspect of Generation R is that it's multi-ethnic. It's located in the city of Rotterdam, which is about half of the population has a sort of Dutch European ancestry, and the rest is mixed other ethnicities, as you can see in the pie chart. And Generation R is a relatively good representation of the city. This is Generation R on one slide. So basically, started in pregnancy on the left side, you see that we have 3 time points of measurements in pregnancy. And again, also here, it's not so much about the individual measurements. What I'm trying to show here is that we have a group of people that we follow at multiple ages, and we measure loads of things at these ages. And because of that, we know a lot about how the children develop, how they grow, how they develop mentally, how they develop in terms of cardiometabolic health, etc. And also their moms, as you can see on the left lower corner. This setup is clearly, we think it's very interesting, but it's not unique. There are many other cohorts that have similar setups, Elfback, Eden, etc., that are NFPC, who are included in LongITools as well. Now, Generation R is run from Erasmus Medical Center, which is the white building in the middle. And as you can see, in the sort of at the back is the city center of Rotterdam. We're about 10 minutes away on foot from the city center. I'm showing you this picture because it's very relevant for us to be located in the heart of the city. The connection to the city of Rotterdam is very strong. We have member of the city of Rotterdam represented in our management team, and there's continuous interaction with them on topics that are important for the city and our findings. So we actively try to keep that close connection with the city and the policymakers. I'm going to show you something about dental caries, not because it's relevant for LongITools in essence. I mean, it is, I guess, relevant, but it's maybe not the first thing that you think about when you think of LongITools, but it's just because I like this simplicity of this and what it can show us. So on the left side, well, on the slide, you can see a map of Rotterdam. You can see there's a river in the middle. We've got the northern part and the southern part, and we've got a number of, I guess, boroughs or areas that are colored by socioeconomic position. And the lighter the color, the stronger the socioeconomic position. And so the sort of better off people, you see them in the north and the east mostly. And then as you go south, it's a little bit more difficult. This is a graph that is based on multiple indicators, so maternal education, income, etc. And this is a graph that we've just made basically on basic demographics. Now, a very simple exercise that our jaw surgery colleagues actually have done is just count the number of children that have cavities, so dental caries. And that's the same map, just colored for dental caries. And you see that it's pretty much, I don't want to say a one-to-one overlap, but you can see the similarities between the two maps. And I think this is one of the reasons why it's important to have studies like this in cities, showing the differences. And this is not to say, oh, you know, those are the bad areas. It's not to point fingers. It's to be able to say, look, these may be areas where prevention is more important, where we should be looking at for preventive action. Now, if we look a bit closer at the environmental factors, again, you see maps of Rotterdam, but this is just the northern part for the people who are interested in the details. So top graph is a map of the air pollution. This is PM10 in this case. And you can see that there are a number of big streets that are colored red. And then again, here you see north and east are a bit more blue and green, so lower levels of air pollution in this case. And then the bottom graph is a similar map, but just for noise levels. And again, you can see the larger streets. It's not a one-to-one, which was also quite interesting, but I'll spare you those details. What we were able to show is that, in this case, PM10, but we can say air pollution exposure during pregnancy is related to things like birth weight, asthma, and brain development. So it's related to child health. And if you look at noise, it's related to shorter sleep. So environmental factors have been related in a single study, Generation R, to various health outcomes in children. Again, and this is my last example from Generation R specifically. If you look at the patterns, so the figure on the left, the patterns of environmental exposures in a cohort like this, you can see that we can actually group people based on their exposures. So in the top graph, you see that there are a number of environmental exposures shown. Red is air pollution, purplish is noise, etc. And then, you know, we've grouped people based on their level of exposure to those factors. So at the top one, you see a pattern of children who are exposed to low levels of air pollution. The red bars are below the zero line. Green space is above the zero line, so high exposure to green space. And then a built environment is mostly below the line, so not so much sort of heavily built environment. So this is what we would think is maybe a good exposure pattern. Low air pollution, high green, not too many buildings. So that's one pattern. Then there's another group in the middle that has sort of quite okay levels of air pollution below the zero line, but the green space is also below the zero line. So not a lot of green around them, and then much more built. So the orange bars are above the zero line, meaning that in terms of air pollution, they're actually doing okay, but the built environment that they live in might be suboptimal. And then at the bottom, a pattern where there's high levels of air pollution, high levels of noise exposure, and also low levels of green and high levels of built exposure. So what we would think is potentially a less optimal exposure pattern. So basically what this graph is showing is that we can find groups of people that have clusters of environmental exposures that are similar. And we've been able to show that suboptimal clusters of these environmental exposures are related to health outcomes, for example, respiratory health. So this is also important information for example, the city to know. So how do we try to contribute to policy? On the left, you see some pictures of an event that we had together with the City Council, where we brought together medical researchers, policymakers, young adolescents at that time, mothers of our adolescents, fathers as well, and where we discussed what should be priorities for policy in the city. And through the work that we do in Generation R, we've contributed to local policy. There's the Rotterdam Youth Policy, to national policy. Sorry, these are in Dutch, but the Healthy Start program of the Ministry of Health. Ministry of Health is one of our funders, and we also have regular meetings with them to update them on our findings. We go and visit them about once to twice every year. And then also contributing to international policies such as the childhood obesity policy of the WHO. Now, clearly, as I said, there are many or multiple cohorts that focus on early life in LongITools, but also across Europe. And we come together in a larger network that's called the EU Child Cohort Network that LongITools has also strongly contributed to. This is a network now of 37 cohorts where we have data on over 250,000 children and their parents. Many of the data have been harmonized. It's been discussed earlier today. And this is a network where we can do similar studies in a larger context. An example of that is this study where we looked at green space exposure during pregnancy in a total sample size of about 70,000 newborns. And we found that it was associated with fetal growth restriction. So higher green space exposure in pregnancy was gave you a lower risk of fetal growth restriction. Interesting here was that this effect was stronger in areas with a lower socioeconomic status. So apparently, socioeconomic status modifies these associations. Not such a pretty picture for this study, but I think quite interesting findings, because in a similar setup, in this case of 60,000 children over 8 cohorts in 11 cities, there were 2 things that were interesting when they looked at socioeconomic position and how socioeconomic position relates to environmental factors. There were some things that were consistent, that were found across cohorts and had very similar patterns regardless of in which cohort you were looking. So low socioeconomic position was associated with things like lower breastfeeding, consumption of healthier foods. So lower consumption of healthier foods, higher TV screen time, more exposure to secondhand smoke, etc. So that was similar across Europe, if you were, or at least across these cohorts. But then there were also things that were different between cohorts. So, for example, the association of socioeconomic position to the urban environment was very strongly context dependent. So in some cohorts, we saw that lower socioeconomic position was related to higher air pollution levels. In other cohorts, lower socioeconomic position was related to lower air pollution levels, for example. This is also important, I think, to realize that we can find bigger patterns across Europe that are consistent, but some things are actually context or location dependent. Now, moving to LongITools, just want to highlight a few papers or a few projects that I think quite nicely show the type of work that we've done in the cohorts and what's been found. And so it's a bit awkward because, as you know, the first authors of these papers are in the room. So if I hope I represent your work well, feel free to jump in. But this is a paper that was led by Ana Gonzalez Suarez from Bristol, where the question was, how do environmental factors relate to blood pressure development across childhood into adolescence and young adulthood? The primary analyses were done in LSPEC and then repeated in 4 other cohorts and confirmed in those cohorts. And basically what was found, you can see it in the graph on the right. So if you look at the dots, every dot represents some environmental exposure. We're interested in everything that's above the dotted line. So basically there's a green dot here, there's a green dot there that represents the findings, the main findings of the study. Basically what you're seeing here is that temperature and humidity during pregnancy are associated with blood pressure development mainly in childhood. And so this is relevant because we know that blood pressure, as we call it, tracks from childhood into adulthood. So children who have higher levels of blood pressure during childhood are more likely to have higher levels of blood pressure during adulthood. We know that increased blood pressure is a risk factor for cardiovascular disease later. So this is important to know. So Anna looked at multiple stages of life and found that childhood, in this case, is where we see the strongest effects. Very briefly, I can show you something that's a hobby of mine, that Claudio is working on with Carl. Also, again, I hope I represent the work well. So the reason I'm showing you this is because it fits so nicely with what I said before. So we wanted to know, okay, so there are environmental exposures. They are associated with childhood blood pressure. That's great and interesting, but why? How can it be that exposure to temperature and humidity in pregnancy is related to childhood blood pressure? So we looked at what we call the metabolomes, so a whole range of compounds that we can measure in the blood. I want you to focus on the bottom part of the figure, so the one with the blue arrows. And basically what Claudio showed was that the humidity and temperature exposure changed levels of a number of these compounds in the blood, and that was related to lower blood pressure. Why is it important that something in the blood changes? It's important because it can help us, if we understand how the environment affects blood pressure in this case, we can figure out which groups are at risk of getting higher blood pressure due to these environmental exposures. We can find them early, we can detect them early, and we can help prevent these negative health outcomes. So this is why the biological mechanisms are important. Final example from LongITools, work by Darren and others. Clearly, I'm mentioning the first authors, but there are many others involved in this. This is in a group of obese study participants where Darren examines the associations of air pollution with cardiometabolic health. You're seeing a picture of PM2.5 in relation to total cholesterol. Basically, what you see is the lines go up, so higher exposure to air pollution is related to higher cholesterol levels. It's not necessarily what we want. But what you also see is 3 different lines: lower, middle, and higher diet quality. And you see that the orange line, which is the lower diet quality, is the steepest of the 3. So the effects are the strongest in the group that has a lower diet quality. Why is this relevant? Because diet is something that we can potentially change. So if we understand this, then that may be a starting point for prevention or intervention measures. So overall, not doing too badly for time. Final 2 slides. Cohort studies with longitudinal follow-up data across the life course. I've shown you early life, but similar work has been done in the older ages. Provide essential information on health and how it develops over time. Timing matters. Because we have information on the entire life course, we can see which periods are most important and where at which time points we may best intervene. Context matters. Some things are the same across cohorts, but other things are different. We need to understand this to be able to do something about them. If we understand why associations occur, then that helps us figure out which groups are at risk and how we can prevent the consequences. Exposures do not exist in isolation. So you see patterns of exposure that are the same for groups within the population. And if we can identify things at the societal and at the personal level that may modify this association, then that can help prevent and treat the consequences. And it's important, I think, also to say that some of the personal level modifying factors also often have a societal component to it. Think about, we can all say diet is something that you can change yourself, but some people live in an environment where it's much easier to have a healthy diet than others. Some people live in an environment where it's much easier to do a lot of physical activity than elsewhere. So I think it's also important to take into account there that there are societal factors influencing those personal level factors as well. So this was in a bit of a, I guess, short overview, some of the cohort work that's been done in LongITools. Clearly, thank you to all the cohort colleagues in LongITools and all the colleagues in LongITools. Some people have specifically contributed to the work that was shown in this presentation, and they're named on this slide. Thanks very much.